Hello, welcome everyone to the Midwestern Vascular Surgical Society webinar for advanced practice providers. We are really excited today for all of our topics to review some new guidelines that are applicable to vascular surgery APPs. My name is Lauren Needler and my colleague Maria Wellenstein we are moderating for you tonight. And I just wanted to point out that the format will be a presenter will speak for about 10 minutes, and then we will do a quick Q&A. If you have any questions, put them in the chat, and Maria and I will relay them to the presenters. And also, our emails are in the chat for anyone who is interested in presenting next year or getting involved in the live meeting. You can email Maria and I your interest, and we will get you connected. So without further ado, Maria, present.
Yes, our first presenter is Dr. Neil Manzacani, and he is from Northwestern Memorial Hospital, and he will present to us on the new SVS guidelines for blunt aortic injuries.
All right. Can you guys see my screen?
Yes.
All righty. Well, Maria and Laura, thanks for the invitation. I'm happy to be here and talk a little bit about the updated SVS clinical practice guidelines on blunt aortic injuries. Let's see. A couple disclosures that are not relevant to what I'm going to be talking about today. Let's see. So blunt aortic injury remains one of the most lethal injuries in trauma care and demands rapid evidence-based information and decision-making. So in 2011, the SVS guidelines were a landmark establishing a grading system and legitimizing TEVAR as the primary repair modality. The 2026 update provides 13 updated recommendations based on more than a decade of evidence. So this talk, we're going to go through what changed, what was confirmed, and what remains unresolved. The 4-grade classification established in 2011 still remains the foundation. So grade 1 represents intimal irregularities, grade 2 represents intramural hematoma, grade 3 pseudoaneurysm, grade 4 is rupture with free extrav. And in real-world practice, grade 3 pseudoaneurysm accounts for about 60% of all identified blunt aortic injury cases, making it the most clinically consequential grade. So in 2011, the SVS recommended non-operative management for grade 1 injuries and TEVAR or open repair for higher grades, immediately after more life-threatening injuries had been addressed. So the recommendations were all level 2C and reflective of practice at the time. So briefly, they suggested endovascular repair preferentially over open repair, urgent repair within 24 hours, serial imaging for type 1 injuries, endovascular repair, regardless of age, if suitable, selective revascularization of the left subclavian artery, routine heparinization at a lower dose. They recommended against routine spinal drainage, general anesthesia, and open femoral exposure. So that was reflective of practice at the time. The new guideline writing group came together to answer each of these questions to update the 2011 guidelines to reflect our current practice. And we'll go through each of these individually, but briefly, there were 7 questions that we'll address. So question 1, should patients with grade 1 and grade 2 blunt injury be treated with non-operative repair or TEVAR? So this is the biggest evolution. So in 2026, this is one of the biggest shifts from 2011. So in 2011, non-operative management was recommended only for grade 1 injury or intimal tear, and grade 2 occupied kind of a gray zone. So many centers treated this operatively, many centers treated this non-operatively. We didn't fully know what to do about this. So in 2026, in patients with grade 1 and grade 2 injury that we're calling minimal aortic injury, the 2026 guidelines recommend definitive non-operative management over TEVAR or open repair. Grade 1 injuries require no routine follow-up imaging, and grade 2 injuries should undergo 1 follow-up CTA to ensure resolution. So this expansion of non-operative management to both grades 1 and 2 is supported by a decade of registry and observational data, Several studies have demonstrated no difference in aortic-related mortality or outcomes when grade 1 or 2 injuries receive non-operative management, with low aortic-related mortality and excellent intermediate-term results. So the clinical implication is that resisting the impulse to treat a grade 2 aortic injury with TEVAR is now guideline supported and important given the young and otherwise healthy trauma population. All right, recommendation 2, do patients with grade 3 blunt aortic injury undergo early or delayed TEVAR? So in 2011, the guidelines generally favored prompt repair of a grade 3 injury with the framework of addressing or competing life-threatening injuries first, but no explicit delay threshold. In 2026, in hemodynamically stable patients with a grade 3 injury, the 2026 guidelines suggest delayed TEVAR of more than 24 hours to allow for management of other associated traumatic injuries. In an unstable patient where the blunt aortic injury is the cause of instability, then urgent repair within 24 hours or emergent intervention is still recommended. So the key distinction is that stability defines the urgency of the procedure. For most grade 3 patients, waiting more than 24 hours to optimize their physiology and competing injuries is now explicitly endorsed in the guidelines instead of implied. So recommendation 3, the question then is, do patients undergoing left subclavian artery coverage or zone 2 coverage for TEVAR after blunt injury require left subclavian revascularization? In 2011, the guidelines generally permitted left subclavian artery coverage without routine revascularization in the trauma setting, acknowledging that the urgency of repair and technical constraints at the time with the available devices. So in 2026, the guidelines suggest that the decision regarding left subclavian revascularization should be based on feasibility and specific anatomic and clinical factors, including a patent Lima LAD bypass graft, a dominant left vertebral artery, or aortic origin of the left vertebral artery. So this reflects a more nuanced and risk stratified approach, acknowledging that the left subclavian artery coverage occurs in about 35 to 40% of TEVAR cases for blunt injury. And there's a significant inverse relationship between left subclavian artery coverage and stroke incidence, making selective revascularization more clinically meaningful. All right, recommendation 4. What's the optimal role of intraoperative systemic anticoagulation in these procedures? In 2011, there was no clear recommendation on intraoperative heparin use and left largely to surgeon discretion in a population with a high bleeding risk and just suggested lower than average heparin use. So in 2026, we suggest that intraoperative anticoagulation can be used at the surgeon's discretion after considering the risk of bleeding and thrombotic complications. For the subgroup of patients with concomitant traumatic brain injury, the current observational studies provide some reassurance that heparinization is not associated with worse intracranial bleeding or neurologic outcomes, but the certainty of this evidence is pretty low, and decisions should be individualized through a multidisciplinary collaboration. So this is a practically useful addition that gives surgeons explicit cover to use heparin thoughtfully rather than avoiding it. All right. Now for surveillance after TEVAR non-operative management. In 2011, the guidelines did not provide a recommendation for long-term surveillance, stating that follow-up after TEVAR remains in evolution. In 2026, the guidelines recommend post-TEVAR surveillance imaging at 1, 6, and 12 months, and then annually. For non-operative injuries, grade 1 requires no follow-up imaging, and grade 2 should have at least one follow-up CTA at 1 to 3 months after injury. So extending surveillance intervals for long-term follow-up strikes a balance between the low but not insignificant late risk of complications, including pseudoaneurysm, stent migration, what have you, and the need to minimize costs and radiation exposure in this young population. All right, recommendation 6. What's the optimal treatment of patients with concomitant solid organ or traumatic brain injury? In 2011, the guidelines acknowledged that competing injuries, they acknowledged competing injuries, but offered limited specific guidelines on decision-making when traumatic brain or solid organ injury was present alongside blunt aortic injuries. In 2026, the guidelines provide a more tiered framework. So in patients with a grade 1 or 2 blunt aortic injury, concomitant brain injury, anti-impulse therapy should not be used, and blood pressure management should prioritize TBI over traumatic brain injury. For grade 3 blunt aortic injuries with a concomitant TBI or solid organ injury, decisions regarding anti-impulse therapy, timing of TEVAR, and intraoperative anticoagulation should be individualized and made in collaboration with trauma and neurosurgery. So this is more practical advice and a more practical advance in the guidelines. So the intersection between blunt aortic injury management and TBI is a very common and difficult clinical scenario. And the 2026 guidelines legitimize the multidisciplinary approach and provide somewhat of a decision-making framework. And then for grade 4, blunt aortic injuries, emergent repair is still recommended. Lastly, what's the role of anti-impulse therapy and non-operative management for blunt aortic injury? Patients with grade 3 blunt traumatic aortic injury, we suggest an anti-impulse therapy as a stabilizing measure until TEVAR is performed if the concomitant injuries do not preclude this approach. So a summary of the major changes is related to the non-operative management of grade 1 and 2 aortic injuries, timing of repair in grade 3 injuries, and management of patients with concomitant brain and solid organ injury, as is commonly seen. So this is a summary of the treatment recommendations based on the grade and the appropriate imaging and timing of reintervention. There are some knowledge gaps that the guidelines acknowledge. One is that high quality evidence in this population is lacking. The published literature relies on retrospective data, multi-center registry collaborations, and all of that impacts the strength of our recommendations. The outstanding questions that we have to answer, maybe in the next iteration, is optimal device sizing in young patients, long-term stent outcomes in a decades-long follow-up window, sex and age-specific outcomes, and the outcomes in centers without dedicated vascular surgery coverage. So I tried to provide a brief overview of these guidelines. Reading the guidelines is kind of like reading the dictionary, but I hope this was a good boiled down version of what's new, what's different, and what the guidelines focus on. So thanks for your attention.
Thank you. One question that comes to mind, and everyone please feel free to put any questions you might have in the webinar chat. So anti-impulse control is only recommended for the grade 3. What do we don't need to do it anymore for the grade 1 and 2, because I think traditionally we have been. Is that something that we can kind of get away from?
Yeah, I think we can start to move away from it. It's not guideline supported, and if there's not going to be any adverse events from a grade 1 or grade 2 injury, then I don't think there's much of a role for medical management anymore. Changing culture is going to take some time, and proving that to ourselves is going to take some time, but I think we're going in that direction.
That's great, because we all know that this patient population often is more tachycardic and more agitated for multiple other reasons. And then what do you
I wonder
think?
if the way to do that is to keep them on anti-impulse therapy until we've proven stability of the dissection, especially for a grade 1 injury, until we know it never really progresses, and then slowly move away from it.
Any thoughts on the greatest impact that this is going to have, other than cost, which I think is going to be huge for the repeat scans that we often do in 48 hours, and medication?
I don't know if it's going to have much of an impact on our practice, at least as of the past 5-6 years or so. The guidelines basically reflect how practice is done today. The original guidelines suggested open femoral exposure. No one hardly ever does that anymore as a routine practice. We're starting to become more lax on our follow-up surveillance for grade 1 injuries, grade 2 injuries, and I don't know many people that still treat a grade 2 injury. So I think the current guidelines basically reflect our current practice and legitimize our current practice and provide some reassurance for some of the gray areas.
Thank you very much. I really appreciate your talk.
Thanks for having me.
Thank you.
That was great. Next, we have Tandia Remeke. We know her as Teddy. She's from the Medical College of Wisconsin, and she is going to be presenting on esmolol versus labetalol in acute aortic dissections. Welcome, Teddy.
Okay, can you hear me now? Okay. Well, my name is Tandia Remigi, and I'm a nurse practitioner at the Medical College of Wisconsin, specifically in the Division of Vascular and Endovascular Surgery. I am going to talk to you guys today about esmolol versus labetalol for acute type B aortic dissection. Um, and we need to start off by what is an acute type B aortic dissection and how should it be treated? A type B aortic dissection is a vascular emergency that's characterized by an intimal flap that risks malperfusion of the cerebral, renal, mesenteric, and peripheral vasculature. This should be treated promptly with optimal medical therapy with strict impulse control, or if there are signs of malperfusion or rupture, this should be treated with emergent surgery. However, I'll be discussing the optimal medical therapy with strict impulse control rather than surgery, so I'll not be discussing surgery during this presentation. So, what is impulse control? Impulse control is systolic blood pressure less than 120 and heart rate less than 80. However, some institutions use systolic blood pressure less than 100 and heart rate less than 60. Why are we talking about this today? So, the University of Wisconsin-Madison recently published this study. It discussed the protocolized management of acute type B aortic dissection and how it reduced disease progression and the need for surgery. And so, overall, this study just highlighted the importance of protocolization for acute type B aortic dissection. This was a single study, a retrospective cohort study that finished in 2025 but was just published in 2026. It really went into detail about what medications were used during this protocol, and this was highlighted here. This is a brief overview of the aortic protocol for ICU management. IV infusions remain the first line, with a beta blocker being first line treatment. First line, however, in their protocol was labetalol, second line being nicardipine, and third line being nitroglycerin. Concurrently, it also immediately we're starting oral antihypertensives, first line being carvedilol 12.5 milligrams, BID, and amlodipine 5 milligrams daily. This was titrated every 12 hours until they reached max dosing, and then second line therapy was initiated with lisinopril and hydrochlorothiazide. However, they did make sure to highlight that pain is properly treated during this time period. A patient who's in pain is often tachycardic and hypertensive. And so, if you're treating their pain without masking the symptoms, you um, can see the blood pressure control. I do want to highlight, however, that 83.3% of patients required second line treatment. Um, and um, these patients, 83.3% required the second line treatment, being nicardipine or nitroglycerin. Um, and so, why are we deciding to use labetalol instead of esmolol? Um, and so, I want to remind you here a little bit about infusions and the and highlight what these look like, especially for a nurse titrating. Each of these medications can be titrated every 15 minutes. And I really want to highlight here the half-life. The half-life of these medications are for esmolol is 2 to 5 minutes, where the half-life of labetalol is 3 to 8 hours. So you're getting a sustained prolonging effect with the labetalol, but with the half-life of esmolol, it's quick on, quick off. So what are the core differences between esmolol and labetalol? So with esmolol, you have both beta 1 selective and no alpha blockade. You have a very fast onset, which is 1 to 2 minutes, and a very short duration, 9 to 15 minutes average. This primarily reduces the heart rate and has minimal to no effect on systemic vascular resistance. With labetalol, on the other hand, you are getting both mixed beta 1 and beta 2, and you are also getting alpha 1 blockade. This has a fast onset as well, so you're getting that immediate effect within 2 to 5 minutes, and it's got that long duration. You're getting the sustained effect for about 2 to 4 hours. This drops the heart rate and the systemic vascular resistance while having a sustained blood pressure lowering effect. I do want to talk a little bit about physiology. So, with the beta 1, it is primarily in the heart and the kidneys, and so you are seeing that beta 1 affecting the um, heart rate and a little bit of the blood pressure. But beta 2 is found in the smooth muscles and your lungs, and you are getting both the lowering of the systemic vascular resistance and the heart rate effect when you have both the beta 1 and the beta 2 um, as well. So you're getting, they say, a 7-to-1 ratio for your blood pressure heart rate control with labetalol compared to esmolol. When you're dealing with these infusions, it's really important to understand the volume status of your patient. So, with the volume status, we know that labetalol infusions require less volume to control blood pressure and heart rate. This allows for the ease of blood pressure control. As we know, a patient who is hypervolemic, their blood pressure is more difficult to control than a patient who is euvolemic. I want to discuss cost savings. So it's important to understand that healthcare is more expensive every single day. And if we can find ways to save costs for the institution, but also save costs for the patient, it's very important to do so. So, esmolol is associated with an increased total drug costs and longer stays in intensive care units, where labetalol is associated with decreased total drug costs and no change in the average length of stay in an intensive care unit. I want to also highlight here that nicardipine is associated with increased total drug costs and longer stays in the intensive care unit. If you remember earlier, about 83.3% of patients required second line treatment with a second line IV management. Esmolol, on average, the median cost is $10,900 for a patient who's in the intensive care unit, where labetalol is associated with drug costs averaging around the range of $3,900, where nicardipine is just about $11,000 for the average cost. So with labetalol, you're getting about 3 times the reduced cost compared to esmolol. However, the disadvantages of labetalol, as we see it as both an advantage and a disadvantage at times, it's the long half-life of this medication. The long half-life is about 3 to 8 hours, creating a sustained effect. This can lead to prolonged hypotension or bradycardia, and labetalol is contraindicated in patients who have severe asthma, acute heart failure decompensation, or are bradycardic to begin with. So overall, the UW-Madison study revealed that having a protocol and allowing for strict medication management revealed that disease progression at the 72-hour mark after optical medical therapy was initiated decreased by 12% post-protocol. And that implementing a protocol allows for decreased length of stay and cost savings for the patient and the hospital system overall. So if we can find ways that allow the patient to save money, allow the hospital system to save money, but also decrease disease progression by 12%. I do want to highlight overall, though, that these medications, not one over the other, is associated with increased disease progression or morbidity or mortality. So overall, these medications are all safe. So if we are looking at more volume management and cost savings, labetalol is the superior choice. Any questions?
Thanks, Teddy. That was great. With the cost saving and the reduced length of stay and volume, it seems like that would outweigh the half-life difficulties potentially. If there was training, that was done, especially with the ICU nurses. And it seems like Madison figured out, how to do that. Did you, in your literature review, note if any other systems were using this or any other countries had used labetalol over esmolol?
The American Heart Association and the European Society of Cardiology recommend using beta blockers for first-line therapy, but they also highlight how important it is that labetalol has such a favorable 7-to-1 ratio for the beta to alpha blocking activity. So it directly affects slowing the heart rate while managing acute hypertensive crisis. So both those major organizations really show how important it is to use labetalol instead of esmolol, or it has that as an option.
Okay, great. Thank you
I
so
had,
much.
I don't have a question, but I just have a comment. One of the issues we run into at my hospital with Esmolol is it comes with a large volume rider, and we cannot get pharmacy to concentrate it. And so oftentimes our patients get fluid overloaded with Esmolol. And I was just curious if that's a universal thing or if that's just our institution that it carries a really large volume.
It definitely carries a very large volume. I just dealt with this with a patient just this last week, where we were also then starting a Bumex drip and starting other medications just to try to get the volume status of these patients under control. Obviously, it's still a great medication, but if we can find ways that we can use labetalol instead of esmolol and get that, reduced volume status for the patient, you're not fighting as much of an uphill battle.
Yeah, absolutely agree.
Thank you very much, Teddy. Next up, we have Megan Reed, nurse practitioner, and she comes from Aurora Medical Center, and she's going to present to us on the new AHA guidelines for lipid management, which came out in 2026.
Thank you. Bear with me while I get this uploaded and shared here. All right. Yep, as they mentioned, my name is Megan over at the Aurora Summit facility. I work in cardiology, so not quite as in-depth as some of the trauma experiences that you guys have. But the new guidelines, some key points is replacing kind of an outdated interface from 2018. A lot of primary prevention, so hopefully kind of down the pipeline interface in regards to hospital-based care. These people will already be on cholesterol control. The emphasis really is on earlier prevention. There's some new risk scores that are being emphasized that I'll speak to, and some risk enhancing features as well. So the goal now is treating dyslipidemia earlier to reduce lifelong risk and exposure to atherogenic lipoproteins. There's a few key populations in which case the guidelines are going to be, or the guidelines are to treat no matter what, no matter if they have heart disease or not. But LDL counts above 160, strong family history. The prevent cohort now, move this out of the way. This prevent calculator, predicts not only a 10-year risk, but a 30-year risk. So, and it's very well tailored to individuals. They stratify as well from a low risk, intermediate risk, high risk, and then there's a very high risk population. The ASCVD equation, this prevent equation brings in like a lot new risk factors. So there's a big push now for cardiometabolic risk. So not just artery disease, but taking into account just a global risk. So renal indices, the use of other medications, as well as BMIs. So kind of classification here in regards to risk stratification based upon the calculator. It's kind of a lengthy calculator. That's kind of one thing I find maybe somewhat challenging, but kind of becomes a place to counsel. Always counseling patients, and then again, identifying risk based upon those metabolic factors. The borderline category, so again, this is more primary or kind of a secondary prevention for people who may have elevated calcium scores. Their target is to have LDL reduction less than 100, as well as non-HDL less than 130, something similar to what's been out there previously. The newer, more aggressive targets would be in the high-risk populations, so targets less than 70. There is another target for those in the very high risk where we're actually trying to achieve. So these are the high risk populations already established, atherosclerosis, LDLs greater than 190 at baseline, and then concomitant diabetes, CKD, or other conditions. The target there, which will come up in a different slide, but the target there is actually moving an LDL less than 55, which is pretty aggressive. Some other things in regards to risk enhancing, so identifying people who might be at target, say the LDL less than 70, or a non-HDL that's kind of equivocal. Triglycerides are kind of this moving target as well. We're really trying to be aggressive and have triglycerides less than 150. And this doesn't necessarily mean adding pharmacotherapy agents, but again, going back to diet, lifestyle recommendations, and then this ApoB. So essentially what it is, it's a subparticle that's on every atherogenic lipoprotein. So ApoB, crucial protein found in atherogenic lipoproteins. It includes kind of all the lousy stuff. So that becomes a way, a much more comprehensive way to identify risk. So you can have an LDL that might be at target, and you'll kind of see the non-HDL being slightly higher. Well, this ApoB can really quantify now, are you at target or are you not? Because this will help incorporate, higher triglycerides or intermediate triglyceride patients. Those targets now we're trying to push below an ApoB less than 80. Another risk enhancer and kind of a new unique guideline, especially in general cardiology, we've screened for a few years now with some resistance lipoprotein A's. So lipoprotein A, the recommendation now is universal screening, all adults, regardless of history. Obviously, the conversation tends to be with those who have family history. You can actually see a genetic implication here. So it's a low density lipoprotein carried in the blood that has unique properties compared to regular LDL particles. It's atherogenic, pro-inflammatory, and has thrombogenic effects, promotes plaque formation, inflammation, and clotting. Again, measured at least once in somebody's lifetime, and can be used again as a risk enhancing profile. It's largely inherited, and we're encouraged to have relatives cascade screened, meaning first degree relatives, children, siblings. If you're a carrier, then they very well could be as well. As of now, there's no true pharmacotherapy that targets this. PCSK9s do to some extent. We don't know the long-term implications of that as of now, but it's really leaning into lifestyle changes. There's a table within the guidelines that emphasize the increased risk. So as the LPA concentration increases, so does your fold increased risk of ASCVD in your lifetime. Another risk enhancer, things like a coronary calcium score. So a lot of institutions, they'll promote these for $45, $50 cash out of pocket. Again, we're trying to aim for a higher age population, so above 40 years old, and potentially some risk factors. The idea behind a coronary calcium score is you've had soft plaques that have had a long enough time to actually heal and become hard. And so therefore it's kind of a premature aging. You get put into, there's a MESA calculator and a few other features, but then you kind of get graded based upon your age. The younger you are, you should have no calcium, and that portends a really good prognostic implication long-term. However, the higher the score, the higher susceptibility to problems down the road. So if you are somebody who has calcium scores even above 100, really we should start having a conversation, maybe even adding an aspirin as preventative care moving forward. Other things though that come in, so we have this conversation a lot, you'll see kind of incidental finding of coronary calcifications, or again, these calcium scores that patients might be panicked by. In general, statins increase calcium scores. That's a therapeutic benefit, as well as exercise. So think of it like a calcification or a callus, if you will, in the intralumen of the arteries. So it doesn't necessarily mean a bad thing. You just want to, I guess, be aware of it. The guidelines here. So the other thing that I haven't spoke to is they're really emphasizing screening younger, like adolescents, and then even screening, as young as like 2 years old for family risk. That's something that primary care and pediatricians. They speak to a lot if you follow those interfaces. Again, for the purpose of this talk, we're kind of talking about the older populations, again, achieving better targets, and then following pharmacotherapy. So again, kind of a summary slide there for the goals. In general, achieving better targets. So treatment modalities, again, the mainstay. So number one for pharmacotherapy, well, number one treatment always is lifestyle, emphasis on lifestyle, Mediterranean diet, and routine exercise. Then when it comes to pharmacotherapy, you've identified enough risk. Statin therapy is still the superior class of indication. High intensity for higher risk individuals, attempting to achieve a 50% reduction in LDL targets for things with atorvastatin and rosuvastatin high dose. You'll see other classifications there, statins. For those who have practiced long enough, there's a lot of resistance to jumping to the highest dose initially. However, that's kind of what we advocate for, especially in acute events, really reducing inflammation and disease burden, and then kind of tailoring to other doses moving forward. Kind of a newer guideline, well, adjunctive therapy. So again, trying to achieve those targets. There's still ezetimibe that has long-term outcome reduction, PCSK9 inhibitors, which are newer to the market, and then bempedoic acid, which is probably our newest agent. The algorithm there kind of emphasizes adding ezetimibe and PCSK9 and or bempedoic acid. Historically, for those who may have been prescribing in the outpatient setting, you always had to start with ezetimibe before you could even attempt authorization for PCSK9 inhibitors. That's no longer part of the guidelines. So if you really need an LDL reduction and you're going to need something above and beyond, traditionally, ezetimibe gets you about a 10 to 15% LDL reduction target. So if you think you're already, your LDL's on a maximum tolerated statin, you need another 50% reduction, you can authorize for a PCSK9. That's per the new guidelines. The other considerations is high triglycerides. As we know, it's a cardiometabolic risk enhancer. So sometimes too, screening for diabetes underlying, as if your A1C is elevated, clearly getting that under control. But if it's truly just a triglyceride problem amongst, counseling, fish oils, Lovaza, Vascepa are the brand name or the, pharmacologic aspects for treating that, and then fibrates as well. So the practical summary for vascular providers. So again, the target achieving for anybody with known ASCVD or peripheral vascular disease is an LDL less than 55. Starting with the high intensity statins, Zetia or PCSK9, there's no longer a sequence and requirement. Measuring the lipoprotein A once in their lifetime. And then considering ApoB when triglycerides are elevated or LDL is already low, but you suspect there's still increased risk. Bempedoic acid, again, I didn't speak much to that. It's an option for statin intolerant patients. There's two different versions of it. Admittedly, it tends to be somewhat cost prohibitive. There's some coupons and cost savings available. And then as of now, there's no evidence that supports de-escalation, even at very low LDL levels, which I know a lot of patients will say, if I'm so low, what should I do with that? We really know that it's going to reduce risk long-term. And that's kind of what the guidelines emphasize. Thank you for your time. If anybody has any questions.
Thank you, Megan. That was great. I do have a question for the ApoA and the ApoB. Are you getting those as baseline before even starting someone on a statin, or are you using that when they're already on a statin?
Yeah, great question. So it kind of depends on the patients and like their aversion to therapy. You don't have to start with it. I'll do it most times if I'm, again, kind of at an intermediate risk. I really need to identify how aggressive we need to be. Most times though, I'll do it for patients who they just had an MI, now they're on maximum tolerated statin, and I really, like they emphasize, you want to promote better risk. So I'll say, I know you're borderline here, this ApoB is above target, and then I'll kind of do serial testing of the ApoBs then until I achieve therapeutic response to, I guess, better. Patients really want data to know that why they're on extra medicine. So that's a really nice staple to use for people.
And then I would assume that the calculator also helps with that too.
Yeah, and it's a dense calculator. For those who haven't used it, it's through, even the medcalc.com. I mean, it takes a few minutes to plug through, but if you have time to sit down, and oftentimes I'll offer patients, especially after calcium scores, I'll do their MESA calculator and then I'll go through that risk panel with them and they can clearly see. Oftentimes I'll just take a screenshot of it, give it to them, let them go home and decide, and follow up, in a few weeks with a phone call. Do you want to start a low dose? And then again, we'll do kind of a review of, how that's where I may follow an ApoB. Your LDL is not bad. You've been told for years that you have a intermediate panel, but this ApoB really does reclassify you into a higher risk. So.
And I just have one last quick question, but are you finding that patients, when they go on the adjunctive therapy, that they're coming off the statins? And my impression is that they should be used in conjunction with each other unless you have an intolerance.
Yeah, very few would we actually stop. Sometimes we'll de-escalate in regards to dose. So for instance, highest tolerated, if you're on an 80 milligrams of atorvastatin and your LDL is coming back then at 25, I'll go to 40. And I'll still revisit, they say tailoring about 8 to 12 weeks. It's somebody like that's already at target. I may wait to 6 months just to avoid too many, lab draws, but guidelines say you can repeat in 2 to 3 months. And I still try to keep them below target. I'm a firm believer, and the guidelines still emphasize statins. So even any amount of statin, and there have been, through kind of lipid management patients, we'll do like 1 day a week of a low dose statin just to keep somebody on that. It just has the biggest pool of data than we've really have in any other pharmacologic agent. So.
Thank you. That was great. Really appreciate it.
Well, I had one quick question.
Oh, yes.
For the lipoprotein A, did you say the first line was your statins or was it the PCSK9?
Good question. So yeah, first line is statins. So you're
It still
treating,
is. Okay.
and you're not expecting to see that level moved. So admittedly, a lipoprotein A, if you were to do serial testing, you may see actually an increase in lipoprotein A values on a statin. I can't explain why, but that's something that I know people who've had them screened through like different lipid clinics will notice that, but we still see better outcomes when we're treating just the overall risk. And so statin remains your number one targeted therapy. Now, PCSK9s will actually reduce that, but like I mentioned, we don't know what that means long term. There are currently some agents that are intended to reduce it. What that means, again, in the future, to be determined.
Thank you so much.
You're welcome. Thank you.
Yeah, that was awesome, Megan. Thank you.
Thanks.
Next, we have Sarah Meyer. She is from Rush University and presenting on the Surviving Sepsis campaign, the sepsis updated guidelines.
Great. Thank you. Okay. So I am Sarah. I'm one of the NPs with vascular and endovascular surgery at Rush. My background real quick was I spent almost 10 years in the cardiovascular, thoracic, and surgical ICU. So critical care has always been very near and dear to me. So I was happy to get this topic, and I have no disclosures to report. A brief overview of the Surviving Sepsis campaign. It was initiated in 2002. And then most recently it released its updated guidelines at the Critical Care Conference in Chicago just this last April. It is quite comprehensive. They do carry over some core fundamentals, and then they address some new topics not previously addressed in prior guidelines. Included in the guidelines are adults and pediatrics, but I will focus on the adults for this topic. And really, like I said, it was very comprehensive. There was 69 people on this panel. They represent 23 countries. They have a broad geographical diversity, and about 40% of the panelists practice in low or middle income counties or countries. So the basic guidelines and the fundamentals stay the same. They're trying to balance a timely treatment, but also limit unnecessary antibiotic exposure and complications for patients who might be at low risk of sepsis. So this is the level of evidence that they used. You'll see the symbol key in the upper left-hand corner. So they made some strong recommendations for, some conditional recommendations for and against, and some strong recommendations against. And within that subcategory, the level of evidence was classified as very low, low, high, or moderate. So I didn't get into the nitty-gritty for the sake of time, but I will highlight some of those strong for and strong against. And again, the verbiage that they use is in the lower right-hand corner of what constituted a strong recommendation is what your stakeholders would want, what clinicians are doing to all or most patients that are the most appropriate and have the best research. And for their research, they reviewed a lot of randomized controlled trials and quality improvement projects and such, which I'll mention in the references. So for screening and early management, they still do recommend performance improvement programs within your institution. They recommend a code sepsis protocol and the use of standardized screening tools. The tools that they highlighted were the NEWS and the MUSE or the SIRS. These look at your basic vital signs, such as respiratory rate, heart rate, blood pressure, temperature, and consciousness. They don't recommend a specific one, but they do recommend a standardized screening tool throughout the institution. They also recommended these tools en route to the hospital. And then the tools that they did kind of throw out, which was kind of dated, was the Q SOFA. If anyone was familiar, they do not recommend that anymore. There's just insufficient data. They still want to get blood cultures as soon as possible, ideally before antibiotic administration, but you don't want to delay antibiotic administration if you're having difficulty with the blood cultures. And they did make a point that one blood culture is better than none. Two is ideal because you want to rule out the contaminant, but anything is better than nothing. And there is still a conditional recommendation to measure lactate. Lactate can help guide your resuscitation. It should be individualized to the patient, and you should shoot for a decreasing lactic acid. You no longer need a quote unquote normal lactate to complete your resuscitation. You just need to see it downtrend. That was one of the things they highlighted. With screening, if a patient has sepsis-induced hypotension or shock, you still want to give that 30 mLs per kg of IV crystalloid within the first 3 hours. So this hasn't changed. The volume is based on actual body weight, or if your patient has a BMI of over 30, you want to use their ideal body weight. You want to give the IV fluid bolus first, followed by the vasopressor support. It says that you can start vasopressors peripherally rather than delaying the administration of pressors until you get central venous access. And they actually reviewed some randomized controlled trials that had patients going the entire pressor use on peripheral IVs instead of getting central lines, depending on what was available at their institution and what resources were available. But, the risk for extravasation and such has decreased as long as you are keeping an eye on that peripheral and monitoring the site closely. We're still shooting for a target MAP goal of over 65 millimeters mercury, unless, and this part is new, unless you are over 65 years old, then the MAP range shifts to 60 to 65. So a little bit less of a goal to wean your pressors and your fluid resuscitation. And they do suggest admitting to the ICU within 6 hours for those patients where we suspect septic shock. For infection, you want to start your antibiotic ideally within 1 hour. If a patient is at low risk for sepsis and they are not in shock, they do allow a time-limited course of rapid investigation, but then ultimately giving the antibiotics within 3 hours. And if there is a low likelihood of infection, you want to defer antimicrobial therapy till either the patient declares themselves or you have a source as to why that patient has abnormal vital signs. With definite or probable sepsis and hypotension, for patients who are en route to the hospital and they have a arrival time of greater than 60 minutes, they are really pushing administration of antimicrobials in the ambulance or in the flight. They urged rapid identification of an infectious source. And if it was an infectious source that could be controlled surgically, they recommend source control within 6 hours. They really said that procalcitonin levels had fallen out of favor, and they said any pathogen-specific rapid diagnosis tests, there was really no one test. So I know procalcitonin's out there, lactic acid is out there. There's no one test that's going to help us identify whether the patient is in sepsis or not. And I'm talking about screening tests. I'm not talking about diagnostic tests for pathogens. So if you are concerned that the patient may have a multi-drug resistant pathogen, you do want to use empirical antimicrobial with coverage. So risks include a previous infection with a multi-drug resistant pathogen, prolonged use of broad spectrum antibiotics, or prolonged hospitalization in the past. And if the patient is low risk, so they're not coming from a nursing home, they haven't had a prolonged hospitalization or anything above, they just recommend against the empiric therapy with the multi-drug resistant coverage. And because the sepsis campaign covers 23 countries, they really don't specify antibiotics specifically, because I think it varies just by practice and by region. But I would think that this would dissuade you from throwing on a vancomycin if the patient has never had any sort of MRSA positive tests. They also recommend against empirical antifungal therapy. And if you do antifungal therapy because of culture-driven data, then they recommend against Candida fungal biomarkers to guide empiric treatment or to dictate when you discontinue that antifungal therapy. They really highlight using an anaerobic coverage, especially with intra-abdominal, gynecological, head and neck infections, any sort of necrotizing soft tissue infection, and a central nervous system abscess or empyema. And they say that if you're going to use a beta-lactam, such as carbapenem, they recommend a prolonged infusion for maintenance as opposed to bolus administration. And then to round out infection, they are really pushing to do a daily assessment of whether or not the patient is clinically doing better. They want to de-escalate antibiotics, and then especially when pathogens are found, tailor antibiotics as soon as is appropriate, and when the patient clinically improves, taking off the antibiotic. So focus on a shorter duration, and obviously antimicrobial stewardship is a really hot topic. For hemodynamic management, they recommend either invasive or non-invasive blood pressure monitoring. Again, a lot of low or middle income countries that might not have access to these. So you go off the patient's clinical status, but the people who do meet indications for invasive blood pressure monitoring are those who have shock, which require high dose, escalating, or multiple vasopressors, if they need frequent arterial blood draws, or if their blood pressure cuff measurements are not accurate, which sometimes we see in our patient population with their subclavian artery stenoses. You want to use balanced crystalloids over 0.9 normal saline, and you want to use crystalloids alone versus crystalloids with albumin. So albumin has also fallen by the wayside. It's not as favorable anymore, and is not based on the evidence. except the patient population who are cirrhotics or have already received large crystalloid volumes, then you can consider albumins. And again, you can use the serial lactates to guide resuscitations. And then I also have in my notes with traumatic brain injury, it's actually okay to use the 0.9 normal saline, and you would never want to use albumin. You want to use dynamic measurements to guide your initial fluid resuscitation versus static measures. So dynamic measures include passive leg raise, stroke volume variation, pulse pressure and pulse pressure variation. Norepinephrine is still going to be your first line. You're going to use this over dopamine epinephrine. For shock and on escalating doses of norepinephrine, you're going to add that vasopressin. And then if they're persistently hypotensive despite the above, you can add epinephrine. If they have concomitant cardiac shock, then you can use norepinephrine or epinephrine as first line. And there's insufficient data for oral midodrine. For your respiratory support, these are going to be the recommendations when a patient has sepsis plus ARDS. The target SpO2 is going to be between 90 and 96. You do want to use high flow nasal cannula as the initial therapy, and you want to use high flow nasal cannula alone. The non-invasive positive pressure, such as CPAP or BiPAP, has kind of fallen out of favor. And the one thing that came up was a trial of awake proning. I think this is a direct sequelae from our COVID era. But now these patients who are awake and not intubated can try proning when they have ARDS. And if they're in the ICU, they should be regularly screened for ARDS. And with the ventilator, they are still targeting a low tidal volume and a low plateau pressure for their ventilator settings. Additional or adjuvant therapies. When the patient has sepsis and they're in the ICU and being treated for septic shock, if they have risk factors for a GI bleed, you want to use your PPIs. Use of the IV corticosteroids is still very much in practice. It is supported, but they downgraded the recommendation just a little bit. So there's ongoing studies looking at that. And then after your initial fluid resuscitation phase, they do recommend fluid removal. So fluid removal, this did have very low evidence, but they are referring to your diuretics, your ultrafiltration, or some form of extracorporeal fluid removal. This is going to be patient dependent based on their cardiorespiratory status, their vasopressor dose, and their clinical course, whether or not they have peripheral edema, what their weights or their I's and O's are. They advise against antipyretic therapy, either pharmacologic or surface cooling. So this is a conditional recommendation. It was a tier lower than a strong recommendation, but they said that antipyretic therapy doesn't improve clinical outcomes. And this does not include the use of Tylenol for pain. And this is separate than therapeutic hypothermia protocols after cardiac arrest. They also advise against IV vitamin C and vitamin D, against IV immunoglobulin, and against plasma exchange or probiotics. And then these were carried over from the same guidelines as 2021. There's a strong recommendation over a restrictive transfusion strategy. So we're talking about blood transfusion. They're a little bit more restrictive with their blood administration. The insulin therapy, you want to put your goal at less than 180, and you want to use pharmacological VTE prophylaxis unless it's contraindicated. And they actually preface or prefer the Lovenox over sub-Q heparin. Suggestions, which were conditional. So again, suggestions, not strong, but early enteral feeding within 3 days. If they have an acute kidney injury that warrants renal replacement therapy, They can use either continuous or intermittent. If you have a severe metabolic acidemia, you want to use a bicarb drip. And they recommended using the pharmacologic VT prophylaxis alone over using actually the SCDs. And I'll keep going just for the sake of time. I'm almost done. For goals of care, they really recommend, and they carry over from the 2021 campaign, addressing goals of care within 3 days after getting admitted to the ICU. There's really no specific standard criteria to identify when to have these goals of care discussions. It should be a collaborative approach between the clinicians and the families. But also before discharge, health systems should ensure that patients who have survived sepsis have the opportunity to execute advanced directives. So giving them an opportunity to have a say in what they would want if the next time were to come around. And for the transitions of care, this felt really intuitive to me, but just a comprehensive medication reconciliation. You can use a pharmacy or a pharmacist, but you don't have to. You should ensure that patients, families, and their PCPs are provided with updated information about their sepsis, their hospitalization, and what happened during their sepsis. And for long-term recovery, they did recommend follow-up services, mental health support. And for people who were on a ventilator more than 2 days, they suggested rehab services. And there was some insufficient evidence kind of ongoing regarding cognition targeted therapies. So my reference was just the critical care medicine publication, but it was an 87-page article published with over 629 references. So they definitely did their due diligence. And like I said, it was really comprehensive.
Awesome. Thank you for reviewing all those 87 pages
Yeah.
for all of us. What would you say are your top 3 takeaway from, these robust guidelines?
Yeah, good question. I think still kind of the standard, the stuff that was carried over was antibiotics within 1 hour of recognition with shock. You can delay it 3 hours if you want to do an investigation into what the culprit could be, but you really want to do that early intervention with antibiotics. Fluid resuscitation is still going to be the 30 cc's per kg, and your norepinephrine is still going to be the first line for those MAP goals 60 to 65 or higher.
Great. Thank you, guys. Thanks, everyone, so much for being here. That was really wonderful. We are so looking forward to seeing you guys all in September at the MVSS 50th conference and the Friday APP session. Again, thank you all, and I hope you guys all have a great night.
Yeah.
Oh, great. Thank you for having me.
Thank you, guys.
Stop sharing. Okay. I'm still trying to figure out how to stop sharing my screen. Sorry. All right. Thank you, guys. It was wonderful meeting all of you.
Yeah, thank you so much.